Good morning, guys. Thank you for joining this MSK AI panel at our booth. Today, the moderator of this session is going to be Dr. Avneesh Chhabra. His designation says he's the Chief of Musculoskeletal Radiology at UT Southwestern, but I've known him personally for quite some time now. I call him the OG of MSK Radiology. So it's the term I picked up from my son. It's a new fine term. And jokes apart, and he is an authority in the MSK radiology, very specifically in MR neurography. All the published articles, you go to any journal, is published few hundreds of them probably, and would have his signature stamp there. I tried to become an MSK radiologist, but I failed, so I moved to the AI world. Uh, and today you're going to moderate this session. He has an extensive experience in working in the space of AI, apart from his clinical experience. We're looking forward to a very interesting, engaging session, which would be so. This is also getting recorded, so I think we have your consent to share it on our YouTube channel too. And as I said, feel free to share as much as confidential information you can share. It's just friends here. Yeah, I'll give the mic over to Dr. Avneesh Chhabra.
Thanks, Vasanta. That's a very kind introduction, and welcome all for this very engaging and innovative session. You want to hear from all the experts from different vendors. So we have. Is there echo or is it fine? It's fine. Okay. All right. So we have John from United Imaging. We have Daniel from Gleamer, Alexis from AZmed, and we have Darren from Radiobotics. So four very innovative companies. I also work with different companies like CARPL.ai. That's my disclosure. And we are trying to give one of these products. I won't tell you which one in our setup, but these are so good. So we'll start with John first to talk about his product portfolio. Thank you, John.
We have a quite large product portfolio. For the MSK part, we have 4 products. One is the bone fracture detection in both CT and DR. Another one is the scoliosis measurements. It's mainly in DR. And the third one is the lower limb alignment. And the last one is for the hip replacement surgery planning. Basically, we provide all the required metric for the hip replacement surgery. That's our product.
Let's introduce products first.
Yeah, so hi everyone. My name's Dan. I'm the business director at Gleamer, and I also look after product marketing as well. We started our journey back in 2017. Our chief medical officer is actually an MSK radiologist. So a little bit of a bias there. He really wanted us to start our journey in musculoskeletal imaging, and our first application that we developed was BoneView, which I think now has actually become really a new standard for bone trauma interpretation. It covers fractures, effusions, dislocations, and bone lesions across the appendicular and axial skeleton, just excluding the cervical spine and the skull to try and align with, international guidance. But since then, we've grown quite rapidly. So now we're covering multiple different use cases within musculoskeletal imaging, but also outside of MSK imaging as well. So one of the things that we've been working on over the past couple of years is developing the Gleamer Copilot. The Gleamer Copilot is the coverage of all of the different applications within our portfolio, and that covers the MSK applications like the BoneView solution, Bone Metrics, which does musculoskeletal measurements across the full body, pediatric bone age as well, and also bone CT applications for bone metastasis. And then outside of that, you have the chest view applications, the breast imaging, and also the lung lesion CT detection models as well.
Hi everyone, I'm Alexis. I'm in charge of sales management in at AZmed. Basically, we are a French company, as you can hear by my accent. We were created in 2018, and we are globally worldwide implemented in 2,500 hospitals in 57 countries. The first project was fracture detection, which is already certified CE, TGA, SFDA, and also FDA 510K for pediatric and adult population. Basically, the goal was to tackle this challenge of high volumetry. Fracture detection is quite easy for quite almost all the radiologists, but the flows for the ER physicians also, we finally discovered that there is some mistakes there. So first we did that in chest, also X-rays, and we finalized MSK with angle measurement and bone age. The goal is really to tackle 90% of the standard X-rays and to help for physicians, for radiologists to optimize the workflow and also to focus really on the patients and on CT, on MRI that takes time, and where patients are sometimes waiting a lot of time on those really specific exams.
Thank you. Thanks for the invitation today. Darren is my name, and I'm with a company, Radiobotics. Radiobotics is a Danish company headquartered in Copenhagen, and you can tell from my lovely Danish accent that I'm then not located there or based there, but I've got a responsibility as SVP, heading up strategic partnerships with Radiobotics. The interesting thing with ourselves is we've developed a solution that's very, very focused on MSK X-ray with RB fracture, and it's we're becoming the kind of one of the leading providers of that solution in the market, and it presents something a little bit different than some of the things that have been kind of presented here already today, where we can actually work in partnership with a lot of other AI companies, and hence why we're quite busy on the partnership side of things, because we've got this comprehensive focus on fracture and MSK. We cover fracture detection, lesions, dislocations, moving towards kind of spine and other pathologies as well. So trying to be the kind of most comprehensive that we can be on the MSK side of things. CE marked, with a big interest in moving towards FDA for 2025. So it's an exciting time for all of us here on the panel, and look forward to having a conversation about different challenges that we face perhaps and other things in the marketplace. So thank you.
Yeah, thanks all for the introduction. So let's start with John first. So John, we heard that you had different products in MSK, from measurements to fracture detection. So let's talk of fractures first. What's the accuracy of your product in extremities and in spine, and is it FDA approved?
We have multiple products. So for the rib fracture detection, it is FDA approved. So when we design the products, we are more a little bit biased to the sensitivity. So I think our sensitivity is beyond 90%, but we sacrifice a little bit specificity, because the idea is this product is very frequently used in the night emergency room situation. So we don't want to, especially usually at that time, the junior radiologists start working, and usually it's very time critical. So we don't want them to miss any detection, but on the other hand, we might provide some false positives. So this is pretty much for.
Great. So let's talk of the ribs. So are you talking about acute fractures or subacute or chronic? And do they impact any sort of management once you detect them?
So right now, we detect different types of lesions in bones, but then we can also categorize them as acute or the long-term fracture. So that's our product design. So besides the property of the fracture, we also provided a position, quite helpful for the radiologist, because when they write a report, they don't have to count the ribs again and again.
All right, this is for Daniel. So Daniel, your product has been around for a long time for fractures. So what's the accuracy for acute versus subacute chronic fractures? And tell us more about extremity versus axial skeleton. And thirdly, I know yours is FDA approved. So let's tackle the first two questions.
Okay, so one of the things that we've really tried to do with the development of the algorithm is ensure that it's generalizable across different populations and different sort of fracture types, etc. as well. So in one of the studies that we did, which was published in the European Journal of Radiology a couple of years back in, a couple of years ago, 2021 actually, we had across all fracture types a sensitivity of 97.8% and a specificity of 88%. But that was obviously back in 2021. So we've been through a fair few iterations of the application since then. The performances have improved quite drastically. It's, as John mentioned, it's a balance between sensitivity and specificity. because you increase one too much, you are at the risk of offsetting the other. So we increase actually both the sensitivity and the specificity in the latest version of the application, now up to 91.8% on the same data set, and we'll continually benchmark against that data set for new applications, new iterations of the BoneView application. It's for both extremities and axial skeleton. Yeah, there isn't a difference across those two, and that's across both an adult and pediatric population. So in that study, there was 30% of the population were pediatrics. Yeah,
That's wonderful. And then one more question for you before we move on to the next speaker. What about benign versus malignant lesions, like pathologic fracture versus benign? So do you have any data on that one?
So the negative predictive value for lesions across all lesion types was 99.8%. If you have okay, so we have a differentiator actually in the model. So it differentiates between benign, infectious, or tumoral origin. And typically there is no significant differences in the performance of the application based on the finding of the fracture, be that pathological or not. It can tell whether it's pathological versus non-pathological in the back end, but we don't actually output that.
Yeah, that'll be something important to develop, because that's what most of the clinicians struggle with. When a fracture comes into the ER or in the clinic, is it because of a tumor that I need to send to a tumor surgeon, or is it just because fracture everybody can see once it's there, right? And patient is complaining, but what is it due to? That's something we could develop or others could develop. Okay. Next question to you, Alexis. So I heard that these softwares can develop, they can detect all these fractures, etc. Does it increase the reading time of the radiologist, or does it decrease the reading time? Any studies on that are you aware of?
The interpretation, basically we have a lot of studies on that because we are talking about the workflow. The goal is to save time, especially for radiologists. So basically, on average, we have like 30% of save time on our FDA published paper. We did it and we proved it. The good thing also, we did a big study with Simon Med Imaging during 6 months, and we calculate the turnover. So basically, between the first lecture to the moment the patient received his final reports, and basically we proved that we reduced by more than 80% the time to send this report. So in terms of quality, it's really important, but also for the patient. I'm thinking also about like the public hospital, a public institution where you have like 2 readings, first one of emergency physicians, second one of radiologists. It's really good for first the emergency physicians, where we have more than 28% of time saved, but also gain of sensitivity and specificity. But also by this turnover, you can like bring back the patients if there is like some fault or errors, and it's a way also to avoid like mistakes.
And then Darren, what's your opinion on that? So if you save 30% of my time, instead of 300,000, can I make 400,000?
Thanks for putting me on the spot there with the commercials as well. It's certainly an interesting debate, because we're seeing kind of mixed maybe reactions and attitudes to that. Something that we've been talking about at the conference here for the last couple of days is around kind of efficiency in triage. So this idea of, being able to segregate our normals and abnormals more effectively and get time efficiency there. And that's of interest for your in-house reporting team, but also maybe for outsourced teleradiology. So there's a whole other debate there too. So it really depends on what you've identified as your use case, how you're actually going to deploy and use that technology. And then ultimately, how are you going to kind of measure this real world evidence of return on investment? Because the return on investment is going to be different for every organization depending on how they're structured and organized. And I think we've all probably seen that across the board. But interesting on the efficiency side. So one of the papers that we're talking about at the event is Kettering. So some work that we've done in Kettering, where we had a situation where there's misfractures and they want to reduce that. And we're over a year reduced by over 86% of missed fractures. So that's very kind of positive impact on workload, positive impact on the efficiency of the actual triage of patients and management of the patient, then in terms of next steps for the care. But it's an interesting debate. We'll probably spend the next 2 hours here talking about that impact, but it's a good one. So thank you.
Oh, that's an interesting answer. I mean, just from statistics, if you're a radiologist, like excellent radiologist, you're still going to all these you may miss 30%, right? And they are in the ROC curve somewhere. Question comes to my mind when he says that you can save 30% of time. So you're saving 30% of time on the fractures which are picked up. But then if you have a pile of 300 x-rays and only 5% of fractures, 95% of the x-rays, you have added distraction time. No fracture, but boxy were coming up and you have to look at them, you have to ignore them or remove them. So that also the wasted time. So is that accounting?
That's a really, really good question. Basically, we proved it also in our database that more than 90% of the x-rays don't show fractures. And on AZmed side, for example, we proved that we are at 99.6% of NPV. So when you have like 90% of x-rays that don't show fractures plus 99.6% of NPV, we are really tackling the volumes on the right time. So that's where we really save time. Also, you have prevalence. So sometimes there is fracture, sometimes there is no fracture inside the clinical studies. So yeah, it's definitely into account.
Well, that's great. We had a great discussion on fracture. Now my question goes back to John. So in my practice is a tertiary care practice, and maybe 3% fractures or 4% fractures. The rest are non-fractures. Means you got to detect the limb alignment, the limb angulation, all sorts of stuff. So you have a product which does measures, right? For hip replacement, for leg length, etc. Has it been used anywhere, or who embraces it most, the orthopods or the radiologists?
That's a very good question. Actually, our finding is that both, because I don't know for US, but in China the system like that. So all the also MSK, this clinical department, they need to sign the prescription in order to let them do for the lower limb alignment. But before getting that through, the measurement just takes such a long time for the radiologist department. So they are not willing to take this kind of prescription. And they even talk to the MSK department that don't assign these patients to us. But now with these tools, so anyway, because when you send a prescription, right, you get some money, you earn something. So they are more willing to send more prescription to the radiologist. And with the help of these tools, because then they can do all these measurements in a much more efficient way. So they are willing to accept more patients to do this kind of lower limb alignment. So we really observe the numbers. So before the AI tool deployed and after the AI tool deployed, even the scanning, the number of this kind of scanning increased. Also, this kind of prescription also increased.
So which setup is that in Canada where they're doing it? Because in our setup, radiologists don't measure it.
So I mean in China, yeah.
So, I mean, I was a medical advisor with Image Biopsy Lab. We had a very similar product they have a zoo of products like llama, hippo, all that. And we got them FDA approved. So llama was approved, hippo was approved. But none of our orthopods ask for it, and the radiologists don't measure it routinely. And those measurements, when they come out, they also have confidence ranges, right? So it's not one measurement, and it's not one measurement which they're going to use for surgery. There are these confidence intervals. So how do you deal with that? You just give them a report like echocardiogram, like all of these measurements are there for this angle and that angle, or you have some instructions like you may need to act on these.
Right now, we give the measurement, but beside the measurement, we also give the picture. On the picture, you can tell exactly what's the starting point, its ending point, which supporting this measurement. Apparently, there might be some the error. So I think given this information, probably it can help them identify which measurement can really be used.
Very interesting. So what's the error rate? Because in our setup, we found almost 15% error rate, where the landmarks were off or the lines are going everywhere. And it depends on the quality of the image also. So how do you ensure there's a good quality and you get good landmarks, and what's the accuracy?
So right now, I don't have the specific number. So, but when we develop the algorithm, the basic idea is we want to try to avoid this. We call it the gross failure. So just as I said, the measurement is completely off. So because we believe that's something which will make the radiologist lose the confidence of the AI tools. But on the other hand, for this kind of small measure, I don't have the numbers with me. Yeah, it's in certain range, but they are using it.
I think it comes back to your original question around efficiency and creating unnecessary tasks. What we find in our world is if we overcomplicate things and provide way too many things that maybe don't need to be provided in an acute setting, it creates inefficiency. So the idea being is, well, what are the most acute settings? Certainly in our world, so we focus on the acute findings, and we have a lower confidence box than for anything that might kind of sit in a benign situation or a long-term healing situation. The idea being here that we don't want to make it more complicated for the end user. And interestingly, we're finding that we have more engagement now from non-radiology clinicians who are engaging with the technology. But in the same train of thought, if you make it more complicated for them, they're going to be contacting radiology. There's going to be more referred to imaging. There's going to be how can we reduce that center doubtful component and concentrate on the positive and negatives? Certainly, that's what we're seeing on the acute side. And the more that you add in there, the more complicated it gets.
Well, absolutely. If they're not measuring in the first place, and now you're giving them all these measurements, adding work for them. So just a question out of curiosity to all of you. For MSK radiologists, how much time they spend on an X-ray? Or how much time it takes them to read a fracture or say even leg length? Any idea?
I'd imagine it's somewhere between 20 seconds and a minute, depending on the organization, their policies and approach to reporting, and also geography, probably.
Depends on all the hospitals. If you are working also in the clinics, for sure, like senior radiologists between like 20 seconds to 1 minute, big maximum if it's like bad quality or child also. The percentage for MSK radiologists, we now know this is really, really low finally on the X-rays. And it's definitely like sometimes the junior radiologists that look at those X-rays and not often the MSK radiologists.
I think actually it can be less than 20 seconds. In certain instances, I think we measured 18 seconds to read an X-ray, but for lens and angle measurements, it can take up to 3 minutes actually. So if you can automate that process, it's a real time killer for the radiologists.
See, the reading the image will be very short, similar in their range, maybe 20 seconds to 30 seconds. But if you do the measurement, probably it takes long.
So I'll tell you, in my experience, it is about 20 seconds, right? So you're right. And then if you include the dictation, so that comes to about 1.5 to 2 minutes. So that means a person of my caliber will read about, if you divide those 2 minutes by your 60 minutes in an hour, you read about 30 X-rays, right? So I read about 40 an hour. Some of my radiologists, they read anywhere from 20 to 30. Okay. But generally, everybody's in that 30 range. So now you add all that distraction time, the measurements which are popping up and all that. How much time would it add to that 20 seconds?
I think you've answered what everybody is kind of thinking here. We find is high-performing radiologists with AI or without AI are probably going to operate at the same level. But anyway, I suppose the point I was going to make is what we're trying to do is actually maybe improve the performance and quality of those who can't report maybe at that rate.
I think you have a big market. There's most of the studies that are out there comparing radiology.
So we did a study actually that was published in Radiology, and there were multiple readers, including 24 readers in total, which included general radiologists, nurse practitioners, exactly from Boston with Professor Ali Gamazi. And we demonstrated in that study that there was a 35% reduction in the reading time or the radiograph interpretation time across all readers. obviously, as Darren just said, it's going to be much higher for the non-radiology readers, but it will be lower for the experts and for the experienced general radiologists. But what do you call a medical student that graduated at the bottom of his class? Doctor, right? He doesn't perform to the same level as that student that graduated top of his class, and that continues throughout the career. So the point that Darren said really kind of lays true for all of the applications. You're bringing up the average.
I mean, we're not denying the scope of it. We are not denying the value of it. It's just it has to be a segmented market where it's used. And it's just like Elon Musk is saying for a long time that you'll have auto drive for 9 years, 10 years. You don't have that yet because one accident is too many, right? So that's the issue there. Okay, let's go back to another topic of scoliosis. So who has products for scoliosis? Okay, all three of you. So tell me a little bit more about the product. Does it look at the whole spine as a block, or it look at individual vertebrae with a cob angle? Like, what's the model you use?
So, always actually we look at each vertebra, but then when we output the results, we are indicating, the global scoliosis status.
They're much the same, actually. So the output will show both the, frontal and lateral spine with the cob angle measurements. There is some configuration that you can do with that as well. So you can have either consecutive or intertwined measurements for cob angles. You can adjust, 2 or 3 measurements dependent on your practice, because we typically see that, different radiologists, different centers will do a different number of measurements. Some may do 2, some may do 3. It just depends on the case. Exactly. Yeah.
Yeah, for us, it's quite the same also. We take it as a block directly. The good thing also with our solution is that we have a lot of partners that give us anonymized data. So we have like EOS images, we have several types of images, more with less or good quality, but also like big angles or less angles. So that's really the good thing with the solution. So it's working on those.
Well, 2 questions on that. So what's the accuracy if there is a compression fracture in that spine? And then secondly, does it give sagittal balance measurements also, like pelvic incidence and all other stuff?
We don't have the number, for the fracture swing, but I believe it will go in the outlet bed. What's the second question?
Sagittal balance measures like pelvic incidence at sepal slope and all that. Do you give all those measurements?
In our product right now, we don't give that.
So we do cover vertebral compression fractures. Off the top of my head, I don't have the exact performances, but we cover the full thoracic lumbar spine. So any fractures that exist within that anatomy, we will cover. Same with lesions that exist within that region as well, or dislocations, whatever it may be. With regards to sagittal balance, we do cover that as part of the measurements application, bone metrics. So we'll be covering like pelvic obliquity, for example, and coronal balance, etc.
Yeah, on our side, like I didn't get precisely, but basically we can detect the fractures if it was your question.
Yeah, if you're a fracture with acute lesion of visibility,
No, basically like the goal is we have a way to filter it in the right way depending the exams you are doing. So basically, depending these exams, we can analyze in the proper way that the physicians or the radiologist wants, if it's only for trauma or if it's for the measurements.
Well, thank you very much, and we would like to close the session unless audience have any questions for our vendors.